Thanks very much, Ravi. I've got a particularly quiet voice, so I have to make sure I use this microphone well. So tranexamic acid, an enormous subject, just like the others that have come today. And what my task is to describe where we are now in terms of tranexamic acid usage in cardiac surgery and cardiac anesthesia. So what I'll do is pick out a few vignettes, really, of what's been going on in the tranexamic acid world, and I won't be able to cover a huge amount of ground. So, as you know, quick recap, activation of the fibrinolytic system is absolutely vital, an integral part of vascular hemostatic mechanisms to ensure vascular patency after injury and bleeding. And the basis of fibrinolysis is the conversion of plasminogen into plasmin. The actions of plasmin are numerous, and having reviewed some of the hematological literature on plasmin recently, enormous and still under discussion and development. Obviously, we know that it cleaves fibrin clots, fibrinogen, and other plasma proteins, but it's also a potent pro-inflammatory compound, particularly with monocytes, and it can produce this massive full-blown activation of chemotaxis and cytokine release, etc. It also activates platelets, and therefore it may be implicated in multi-organ failure and tissue damage post-cardiac surgery, where there has been massive conversion of plasminogen to plasmin. Tranexamic acid, as you know, is a lysine analogue, one of the group that inhibits plasmin-mediated fibrinolysis by forming a reversible complex with plasminogen. Now, there's a lot of debate about the tranexamic acid levels in plasma that are required to achieve fibrinolysis, and I found variable target concentrations of between 30 and 127 micromolar per litre, which is actually a huge range, and different authors were reasonably convinced about the range that they'd quoted. If you want complete inhibition of fibrinolysis, actually you need over 600 micromolar per litre. But if you only want 80%, then perhaps a concentration of 64 is adequate. So you can see there's this enormous range of possible target plasma concentrations with no clear indication which is correct or where we should be going or anything much else about it, really. So not much in the literature in terms of number of papers, but an extraordinary range of target plasma tranexamic acid levels. Now, that's just to inhibit fibrinolysis, and if you want to actually directly inhibit plasmin activity and possibly impact on the pro-inflammatory effects of plasmin and the antiplatelet effects, then you need considerably higher levels than this. However, what we do know is that tranexamic acid significantly reduces bleeding and blood product usage in cardiac surgery, and this is probably the fourth time that paper's been quoted today. And the same with this, really. The use of antifibrinolytics in cardiac surgery, they regard as a level 1A supporting evidence, so we should be doing it. And at the moment, tranexamic acid is really our major option. So we don't know what the plasma levels really should be in these wide limits. We don't really know what the dose should be because of that. And although there are extraordinary numbers of papers in the literature about this, the dosing range is absolutely massive, at least tenfold, and that's probably the acceptable dosing ranges, much wider if you include all the very small studies. Many of the dosing regimen reported as effective in reducing bleeding actually are inadequate to maintain the minimum plasma levels to induce fibrinolysis. To inhibit fibrinolysis. And what I've done here is listed three of the most commonly reported dosing regimen. You can see the extraordinary difference between them. The 10 milligrams per kilo dosage plus 1 milligram per kilo per hour was reported in Horo in about 2002 and was the lowest possible dose in a dose-finding study that was associated with a reduction in bleeding. So he regarded this as an effective dose, and this dose was used in a lot of subsequent studies on that basis. In high-risk patients, 100 milligrams per kilo is a bolus, which in an 80-kilogram patient is obviously 8 grams. Maybe more than a lot of us use, actually, but that is also widely quoted as an acceptable dose for high-risk patients. And the third dosing regimen, I think you'll probably recognise from the BART study. If you give tranexamic acid as a single bolus dose and your patient has a prolonged bypass time, then the likelihood of having effective plasma levels in the early post-operative period in order to inhibit fibrinolysis is pretty low, actually. So I don't think we can really support the single bolus dose approach. So there's limited and conflicting evidence about the pharmacokinetics and pharmacodynamics of tranexamic acid. There are 2 and 3 compartment models quoted in the literature. Cardiopulmonary bypass makes it even more complicated because it increases the central compartment and decreases the clearance, and obviously everybody's on bypass for a different length of time. And renal impairment is a further spanner in the works. We know that patients who have renal impairment preoperatively have higher levels of tranexamic acid post-bypass than those that don't. So this was an interesting pharmacokinetic study done by Dowd in Toronto. And what she did was quite clever, I think, in that she looked at 3 dosing regimens. So she looked at Horo's dosing of 1 milligram per kilo per hour and measured the plasma tranexamic acid concentration achieved 15 minutes after that initial bolus dose, and then set up a dosing regimen in order to maintain that level throughout the duration of the surgery. So in that situation, in order to maintain that plasma concentration, you needed to give 12.5 milligrams per kilo at the beginning, 1 milligram per kilo into the bypass circuit, and infuse 6.5 milligrams per kilo per hour for the rest of the surgery and into the post-operative period. Now, her recommendation 2, which is the bottom one, I'm sorry it's a bit hazy, this one, is based on the same dose of Horo, but this time she waited until immediately pre-bypass, measured the plasma concentration then, and aimed to keep the plasma concentration of tranexamic acid at that level throughout the rest of the surgery with the following dosing regimen, so 8, 0, 6, and 4 milligrams per kilo per hour. Now you can see that that keeps the plasma concentration here at, I think it's 334 and 211, so well above those levels that were needed for reasonable fibrinolysis if you accept that you get inhibition of fibrinolysis, if you accept that you get 80% inhibition at a concentration of 64 micromolar per litre. And then the third dose she looked at was the 100 milligrams per kilo, so this one, measured the plasma levels 15 minutes post infusion of that large bolus dose at the beginning, and then aimed to keep the plasma levels at that level throughout bypass and beyond. And that was 800 micromolar per litre. So much, much higher if you want to follow a high dose regimen for high risk patients. And it's possible that this sort of dosing will impact on anti-inflammatory effects and platelet protection. And that was why that protocol, I believe, was used in the BART study. And I won't go into any more about that because obviously that's your territory, but it was very interesting for me to tease that out to see why that was used. So they're going for the maximum dosing regimen to make sure that the tranexamic acid is given at an effective dose. So I just want to touch on this because it's difficult to talk about tranexamic acid without talking about the BART study. But as you know, all I'm going to say, it was a reasonable size study of high-risk cardiac patients randomly assigned to 3 groups. It showed a modest reduction in the risk of massive bleeding in the Aprotinin group, but was terminated early. And this is why it was terminated early. We can debate forever whether that was right or wrong. But there was an excess in the Aprotinin group of deaths. And so that led to, at that stage, the demise of Aprotinin really in the UK market in all but a few pockets. And this led to an opportunity for this German group to look at pre- and post-removal of Aprotinin from the market. And so they compared, I'm afraid it's a retrospective study again, but they compared 5 months of patients who had Aprotinin with 5 months who received tranexamic acid at the time of a clear changeover in practice. And what they found was, unsurprisingly, the Aprotinin group bled less. I don't think any of us will find that surprising in all 4 groups. These are all patients, cabbages, valves, and high risk. So no surprises there. And then they looked at the outcomes, and they found that perhaps there were more myocardial infarctions in the cabbage subgroup, a bit more renal failure. Overall, a bit more myocardial infarction in the Aprotinin group. And then the thing I want you to just look at here is the increased incidence of fits in 3 out of 4 of the tranexamic acid groups, not the cabbage group, but the other 3 groups showed a significant increased incidence of fits with tranexamic acid. And I know that Andy and you have done some work in this area as well. This is the other thing they showed, an excess death rate, purely observational, retrospective study, excess death rate in the Aprotinin group. So just to look at the seizures, the mechanism of this is not really very clearly elucidated. It may be due to changes in regional or global blood flow, but it's probably more likely to be due to the similarities in the structure of tranexamic acid to GABA-A. They're both very small molecules. If you inhibit the inhibitory neurohormone GABA-A, then you increase excitability in the brain and there's more risk of seizures. And tranexamic acid has been shown to cause dose-dependent hyperexcitability in rats, so increasing doses, more convulsions when it's applied directly to their brains. The other thing about cardiac surgery, of course, is there is this general inflammatory response, cerebral emboli, and it's likely that the integrity of the blood-brain barrier is impaired, and the concentration of tranexamic acid actually around the brain may be higher than we're expecting it from in vitro studies. Of course, as we get older, and any previous strokes or undetected cerebral injuries can further reduce the seizure threshold, so this population is at risk, the cardiac surgical population. So this is just very briefly looking at the temporal relationship between the withdrawal of aprotinin and the increase in risk of stroke seen in this German study. They looked at predictors, multivariate predictors of early seizure, and I just have to mention that this is within 24 hours of surgery with no new lesions on the CT or MRI, and no residual neurological deficit once the fitting has ceased. So they looked at multivariate predictors, and they found that, I'll go back to that one. They found that age over 75, well, we're not surprised, are we? Open left-sided chamber procedures, more emboli perhaps. They're often bigger procedures. Preoperative renal failure, well, we know we've got higher levels of tranexamic acid post-bypass in those patients, but we also have higher levels of cephalosporins, which are known to cause fits in cardiac surgical patients. And so the additive effect of those two may well be influential. Peripheral vascular disease may mean cerebral vascular disease. And at the bottom there, tranexamic acid in a dose greater than 100 milligrams per kilo, the dose that we have chosen as our high dose regimen, the dose that was used in the BART protocol. Okay, they also looked at in-hospital outcomes, and they found, that these patients who had seizures were mechanically ventilated for longer, they developed renal failure, and they were in the intensive care unit also for longer. But they didn't show an excess mortality or an increased length of hospital stay, so we're not quite sure about the the relevance of these early post-operative fits without residual neurological sequelae. And this just shows us there is an inflection really around the 100 milligram per kilo mark. These are the 95 confidence intervals on the incidence of seizures. Okay, the only other item I want to touch on is the CRASH-2 trial, which was widely reported in the media because, of course, this is going to make an enormous impact on people surviving after trauma, and there are parallels between trauma and surgery, of course. So we have the aim was to assess the effects of early administration of tranexamic acid in trauma. Lovely, huge, multinational study with 20,000 patients, and they were randomized to a loading dose of 1 gram plus 1 gram over 8 hours, which would put them nicely into that plasma range for inhibiting at least 80% of fibrinolysis. Primary outcomes were death, vascular occlusive events, and blood transfusion. And they showed, interestingly, that there was an all-cause reduction in mortality with the patients that were treated with tranexamic acid, with no apparent increase at this dose of vascular occlusive events. Early treatment is vital. And although there were no statistically significant differences in transfusion requirements, it has been estimated that the widespread use of tranexamic acid could save up to 100,000 lives per year around the globe from trauma. So where are we now, if I get back to my proper question? We know that tranexamic acid competitively binds to plasminogen and will also at higher doses directly inhibit plasmin. We don't know what the correct target plasma concentration for these effects are, particularly the latter effect relating to anti-inflammatory and platelet effects. We know that tranexamic acid reduces blood loss and transfusion following cardiac surgery. We don't know the relationship between our target blood concentration, if we knew that, what that was, and bleeding. That remains complex. And also the optimal dose, although there is a bit more clarity with Dowd's paper, the optimal dose to achieve that target concentration remains really fairly unclear. We do know that a single bolus dose at the beginning of surgery, particularly if the bypass time is long, is not going to give you much protection in that early post-operative period. But we still don't know what the optimal dose is clear. Can you see a theme coming through here? And the pharmacokinetic studies suggest that a bolus plus infusion is the most appropriate dosing regimen. We know that. But do we need that high-dose regimen for all our patients, or should we be tailoring our approach much more closely to different groups of patients? We should continue our dosing into the post-operative period, but how long for? If you continue the high-dose regimen for more than 5 hours, then you're over 100 milligrams per kilo, and you may be getting an increased risk of fitting. We don't know what the significance of these fits are, really, whether it's a problem or not, but we do know that it happens above that dose particularly. And it may be appropriate to reduce our dosage in renal failure, for example, but we don't know the optimum dose in renal failure. We do know that if it's given in trauma early, it will reduce all-cause mortality. Is this transferable to cardiac surgery? If you're going to give it, I would suggest that you would give it early. And aprotinin will return. Where does tranexamic acid refit into that picture? So, final one. So we need more good quality pharmacokinetic and dosing studies to tease out the required plasma concentrations and to optimize our dosing in different patient groups. On a personal basis, if you're a cardiothoracic anaesthetist, you might want to tailor your dosing regimen to the individual patient. So take into account their age, take into account their renal function and the length of bypass. And continue your tranexamic acid into the post-operative period. Aprotinin will be back. We will need to repeat the BART study and other similar large-scale randomized controlled trials to re-examine the relationship between these two drugs and what should be chosen in what subgroup. Thank you.
There's time for one question.
Thank you, Stevie Cheng from London, Ontario. Thank you, Andrea, for the presentation. And just a comment regarding the seizure with TA. When we look at the data, actually with a case series, John Merkin, also from our center, published that it's not the necessary 100 milligram per kilo, that dosage that were back in 2002 is our study with Noreen Dow, who is a fellow with us at that time. And we have a pharmacokinetic study. The maximum 100 milligram per kilo is probably the maximum you should go to, even for high-risk patient. When we look at the case series for those people who surge into seizure, because suddenly when aprotinin stop, everybody give more and more of the antifibrinolytic. They think more is better. And then what happened in the ICU when we see patients seizing, those are 200 milligram per kilo, those cumulative of 300 milligram kilo. And the association factor is indicate not only age, but also patient open chamber and also on ANSEF. When they are on 2 gram big dose Q8 for 1 or 2 more days, with open chamber, they start seizing. And those are the relationship of the synergistic effect that you mentioned. But
yes,
once we have reduced the dose, make sure that they don't over 100 milligram, I don't think we see that anymore for this.
No, certainly the patients that I've seen fitting with it causes huge consternation in the surgeons. They get very distressed if they see a patient fitting in ITU, understandably. But they have not been in a high dosage group, so it can happen below that dose, but much less frequently. Yeah.
Good. Thanks very much, Andrea.
Thank you.